Bring up my email. Let me get it. Verify it's you. There it is. Okay, so Imani and Ashley are not going to be here. All right, so we'll give a shout out to Imani and Ashley first. Did you start the camera?
I did.
A little shout out to Imani and Ashley. Sorry you couldn't be here. Make sure you get that shuttle service worked out. Okay. Enough of that. So we looked at the learning objectives. Like I said, on history, the midterm is going to be, I want you to do well. It's not like I don't want. I'm not trying to trick you up. I'm not trying to do anything. I'm just trying to make sure that you understand what is important, because when you're looking at in the first year of dental school, it's hard to tell all this stuff, all these classes and everything, like what's important. You know, how do you put all this in a framework? So like I said the very first day, part of the lectures, I hope, is to give you that framework, because otherwise we could just have you read the book. Right, so the whole idea of the lectures and the little vignettes that I did that are a few years ago that are short are really good too, because that's, if you don't have a lot of time to read the whole chapter, or you don't want to look at these hour-long videos, if you just look at those little snippets, like they only take like 8 minutes. So just make sure you go over those, and the things that are in those are obviously the most critical points. So what we do in class is try to amplify somewhat those critical things. Is the person back with their bagel?
No, but don't worry about her.
Okay, we'll start with that. All right. No one's back with their bagel. We can't say anything really important until then. All right, so we'll bring this down. It's probably me from last time. Maybe somebody else is using it. Doesn't look like me. Looks like someone else. Just the bagel.
No, she'll sit back here.
Still not back? Let me know when she's here.
Okay.
I'm hungry, actually, so that's why I'm hoping that she brought 2 bagels.
Want me to tell her to?
No.
You sure?
Yeah, I'm sure. I just had lunch. I was
Okay.
just kidding her. That she should bring a bagel for everyone. You know what they said? I don't see anything to erase the board with. I better put my eraser back.
There's one right there.
Where?
On my counter.
Oh, beautiful. Thank you.
No problem.
That's what I need. Okay, so today we're going to talk about mandible, which to me is probably the single most complex bone in the body, because it just has so many different functions in it. It's so different from every other bone in the body. And the thing that makes the mandible in the face unique is that if you have a person and you're just looking at their skull, the first thing that you notice is all of the other bones of the face are part of this piece, right? And this piece is separate. So the key thing to remember to begin with is the fact the mandible is a separate bone. It's not articulated in any way the way the other bones of the face are. All the other ones we talked about are all joined together by sutures. Okay? But the mandible is put together with the rest of the facial skeleton through the temporomandibular joint. So in fact, in dentistry, you know, we often say the joint, right? So when you get out, if you're in dental school and you're talking to dental school classmates and things like that, we could just say the joint, right? Because we only have one. We have 2 really, right and left, but we only have one that's the joint. So, but if you go outside, like we're going to do some interprofessional education with the nursing school, and we start saying the joint, they're not going to know what we're talking about because there's other joints. But all the other joints are really simple, and this one's really complex. So we're the only ones that really understand this one, okay, the temporomandibular joint. So the idea of the temporomandibular joint and how the mandible connects to the maxilla through the temporomandibular joint is the subject of the next lecture. So for now, I just want to talk about the mandible as a bone, as a separate bone. And one of the very, very first things, oh, the bagel person's
It's
back?
not a
Good.
bagel.
Yeah.
It's chicken wing.
Oh, she got chicken. Here we were all expecting a bagel. But did you get enough for everybody? That's what we said. Yeah, how many chicken wings did you get?
Too long. The chicken
Okay,
wings
all right.
were-
Chicken wings were ready?
Yeah.
All right. So anyway, enjoy your chicken wings. So the one thing to remember on the mandible, okay, is that in the adult, unlike the maxilla, the mandible has a right and a left side, but they're connected at the middle. So there's no way that you can expand or widen a mandible in a human. Okay? Now, if you're looking at someone, if you're looking at like cows and things, they have two mandibles, right? So there's lots of animals where the mandible is two bones. It's just like the maxilla, it's a right and a left half. But in humans, it's one bone. So don't let anybody ever tell you they're going to expand the base of the mandible. It can't be done. There's no mid-palatal suture. There's nothing that you can expand. Okay, yes.
In the past, I've met people who said they've had a palate expander
Yes.
for mandible. Does that do anything, or is that?
It pushes the teeth.
So it's more to tip the teeth
It
out?
tips the teeth, no matter what you do, because now you know. See, before you didn't have that knowledge. Now you've got the knowledge. And believe me, there's plenty of misinformation on the internet. Okay? So this is where, what I've noticed about Wikipedia is that anything I know a lot about, Wikipedia is wrong. But if I don't know that much about something, when I read Wikipedia, it makes sense to me. So I have to believe that in general they're right, but the details are wrong. Yes?
In utero, is the palatal bones are fusing together, is this growing at the same time?
That's
Or
a
does that go
very
first
good
and then-
question. When the mandible is formed, okay, when it's formed in embryologic state, there actually is a right and a left half. And it fuses in the midline, and there's a mandibular midline, suture in utero. But that fuses way
Is
before
that
birth.
a way before?
Way before. There's no one born that has a midline suture anymore, or any midline thing. It's not two bones. But when it's formed, there's a centerpiece. It's not joined together. So if you looked at an embryo, then you would see that there would be a right and a left half, but not in a human. Yes.
And this
Well,
may
there are
be
two questions,
something
yeah.
that you're gonna cover, so
Might be.
I apologize, but I'm just still not clear, even from last semester, the connection between Meckel's cartilage and.
Ah, that's a great question. Since you're not clear about it, I'll straighten it out right now. Okay?
So,
Yeah, is
Okay,
your
yeah.
question about Meckel's cartilage too?
No.
Wait 1 minute and let me answer his Meckel's cartilage question because it's a great one, okay? And it's one that shows up all the time on boards, okay? Meckel's cartilage, what's the relationship between Meckel's cartilage and the mandible?
It doesn't seem to be the same, but it does seem to be the same.
Yes, exactly. That's exactly what he's saying is really good. Meckel's cartilage, because in the embryo, you don't have the bone right away, okay? Meckel's cartilage is what we would call a primordial mandible. It's a primordial cartilage. In other words, it's a cartilage that only has remnants in the adult, right? The malleus and the incus are the remnants of Meckel's cartilage. Well, what happened to the rest of it? Okay, the rest of it just gets resorbed. It's not there. But Meckel's cartilage does allow the right and left halves of the face like that to have some sort of breadth. So the tongue, when it's developing, everything doesn't collapse to the middle. So it's the Meckel's cartilage is there, but importantly, and this is the thing to remember, the mandible is not formed from Meckel's cartilage. The mandible is not formed from Meckel's cartilage.
I think that's my question, how do you have it in place?
Yes.
And then the new bone, but it doesn't come from it.
Exactly. So the mandible develops laterally to Meckel's cartilage. And so the mandible is a condensation. It's an intermembranous bone of origin. So you remember intramembranous? What does intramembranous mean? Bahare sits right at the front, so she always must know these answers. Or I'll tell Robbie. It's got to be somebody I can see today. Or Austin. Okay. If it's not formed from cartilage, we call that endochondral, right? So if it's formed directly into bone, it's another name. It starts out intramembranous. Okay. Intramembranous. So the mandible by and large, is an intramembranous bone. Okay, it's an intramembranous bone. It's formed directly as the bone. The only part of the mandible that's not formed intramembranously is the part I'm holding in my hand, which is what part? The condyle. So the condyle has a cartilage. But now the condylar cartilage is weird. Okay, there's a whole chapter in the book about how weird it is. Okay, but the thing is to remember that it's a secondary cartilage. Meckel's cartilage is a primary cartilage. That means it's there in the embryo. This comes about, the condyle is secondary, comes back after the primary cartilages. Okay, so you got Meckel's cartilage is a primary cartilage, but it goes away except for what two bones then, Brad? There you go. All right, that's always a border question.
Make sure I'm
Yes.
clear, so Meckel's cartilage invades, the tongue comes in.
Meckel's cartilage forms directly from mesenchymal stem cells. So from mesenchymal stem cells, you get Meckel's cartilage. Okay, so remember, mesenchymal stem cells are pluripotential, right? Pluripotential, Libby? Pluripotential, what does it mean? Like they can go lots of different directions, okay? So the cell's not differentiated. So it's an undifferentiated mesenchymal cell. Some of these undifferentiated mesenchymal cells that start, remember how the human starts? Okay, if we start at the beginning, you know, there's a sperm and an egg and they come together. Now you've got one cell and then that cell divides and it divides. And then you get a glob. Okay, and then pretty soon you get a glob, you get a tube. Okay, and then once you get the tube, then you start to get the face, because the face comes from the neural crest cells that wrap around the front. And Bruce Latimer is going to talk more about that. But at some point, undifferentiated mesenchymal stem cells differentiate into cartilage that becomes Meckel's cartilage. So that's where that comes from. A different group of undifferentiated mesenchymal stem cells differentiate into bone directly, and that's where the mandible is formed.
Once the mandible surrounds the cartilage, where does the cartilage go?
It gets resorbed, just like, you know, it gets dissolved, it gets eaten up by chondroclasts. We call them chondroclasts because they eat cartilage, but yes, exactly. So it's resorbed by that process. And then in the adult, you don't see it anymore. Okay, except for two places. In the ear, the malleus and the incus. Okay? So the third ear bone, the stapes, where does that come from? That's always a board question. Reichert's cartilage. Okay? Reichert's cartilage. So the malleus and the incus come from Meckel's cartilage, the incus comes. That's not part of my lecture, but I went over it just because it was interesting. Now, Meckel's cartilage is there first, but it goes away. Yes?
Is it reasonable then, in a neonate, you would complete a newborn, whatever space there is between the tongue and the lingual aspect of the mandible is where Meckel's cartilage was, or it's not that simple?
Well, yeah, in a way, yes. But look at what we're talking about. This is the neonatal mandible, okay? It's almost a straight bone. So, yes, the Meckel's cartilage was in the inside, but it's no longer there. But your question is the floor of the mouth and everything is right there. And that bone turns into this bone, right? So just take the two. Imagine that. I mean, imagine that. Pass that around. I mean, that's pretty amazing, actually. It is one of the most amazing stories in growth and development, is how something that looks like this, turns into something that looks like this, or something that looks like this. These are huge. But what do we know are the two processes that are involved in this? What are the two processes? Remodeling is one. What's the other one? Displacement. So all of these changes is amazing. Yes.
But are there growth plates, or you know?
There's no growth plates.
So how's the?
That's why we study how the mandible grows. The mandible is so complicated because you take this bone, which is really pretty simple. It's almost and really this is probably maybe newborn just before birth, because you could, if I pass this around, don't break it, because there, you could see there's a slight midline suture. So it's probably right before birth. But that bone's almost straight. Bone's almost straight. And eventually, like, it starts getting more and more upright. Why is it getting more and more upright? What's the direction of displacement of the bones of the face downward and forward. As it's going downward and forward, the mandible starts almost as a flat bone. Somehow it's got to get a vertical component of growth. So how does it get a vertical component of growth? Okay, it's a combination of two things, but mostly it's the ramus, right? It's mostly, all of a sudden, this posterior appendage really starts to grow a lot. And it continues to grow vertically as the face grows vertically. I'll pass these around just so you can have something to do while you're just sitting there. Okay, so
Look at that.
finally, when you get to the adult mandible, you know, and here's a couple more, just so make sure I get all my mandibles back. But it's really interesting to look at some of these really, really young mandibles, and you can tell by the teeth how old they are. You know, they're going to be really, really young. But the mandible starts out almost flat. So it is, here's just a, oh, here's a little tiny one. All right, here, ready? Don't lose it. All right, so the mandible starts out really small and almost a flat bone like this, okay? Not even so much like that, just like this, right? Starts out with this little flat bone like that, okay? And the only motion that you need when the mandible is firstly formed, it's not a very dark line. Let me see if I can make it work. Okay, is this, forward and back, right? So babies don't have to come out and chew anything. They just have to be able to suck and swallow. So the mandible, when it's first formed, is designed for sucking. It's designed for a forward and back movement. It's not. It doesn't have the same movement that we see now when you have an articulator. The articulator is more to look at. It simulates more of the adult mandible, right? So the adult mandible, like that, this is what we're trying to simulate with the articulator, okay? And so this part, I see somebody with an articulator there. So this part, right there, if you look at the articulators, people that have them, the articulator, this part right here, okay, is the lower member of the articulator, right? It's like this, it goes down, and then it does this, right? And then you put your cast on it, and that's the condyle. That's what the articulator does, okay?
So, do infants not have side shift?
They don't have anything, they just go forward and back. They don't even have the musculature to do it yet. They can, but they don't. The muscles just go forward and back and forward and back and forward and back. They can yawn, things like that, but there's no actual mastication. So you don't have that post-cellus diaphragm and all that kind of stuff till you get old. So you get teeth. You know, its teeth start to then have to develop with the mandible, so as the mandible is developing, it's developing in concert with the dentition. It's a complicated process. In order to understand this thing, I like to take the mandible and I like to divide it into functional component parts, So, if we take the mandible and we divide it and we say each part of this super complicated bone, okay, has a role, a physiologic role to play, and we divide this, and we just number in 1, 2, 3, 4, and 5, we say the mandible has 5 functional areas. And it's not like I do this so you have a framework of starting to understand this bone. Because it's really complicated to just try to grasp it all at once. So we're going to break it down into pieces, little pieces, parts. All the pieces are connected together. There's no interstitial growth, right? Why? Because bone can't grow interstitially. So the condyle of the mandible, we're going to talk more about the condyle. But if we look now at this bone and we look at the functions of each part, the function of the condyle is articulation. So the primary function of the condyle is articulation. It's confusing to people that first look at the mandible because they know that there's the condylar cartilage. And we know if we look at cartilage in the cranial base or in the long bones, what's the primary function of the synchondrosal cartilage or the primary function of the epiphyseal cartilage? What's the primary function?
Growth?
Growth. Exactly. So the primary function, most of the time, when we see cartilage, is growth. So we can make a mistake when we start looking at the mandible. The mandible is different. The cartilage of the mandibular condyle, its primary function is articulation. It's able to adapt all throughout your life. You can get cartilage adaptation or bone adaptation through endochondral growth. Endochondral meaning first it grows in cartilage, then it's converted to bone. So throughout your whole life, the condyle can adapt. Okay, and so 1,000,000 years ago, before you were born, people thought that the condylar cartilage was like the long bone cartilage. We don't think that anymore. We know it's not that way. Okay, the condylar cartilage primarily is for articulation. Now, is it involved in growth and development? Yes, it is, but it's a much smaller role. Okay, the main role is articulation. What about something like this? This part, number 2, what do you call that? Coronate process. So the coronate process has a fairly rigid, sort of a very specific physiological role. Who knows what it is? Mike Landers will be so proud.
Stops the mandible from going.
Yeah, it stops the mandible, but what is the happens at the coronoid process? Mike, are you listening? All right. It's the attachment of the temporalis muscle. The temporalis muscle has its origin here in the temporal fossa, but its insertion is on the coronoid process. So right here is where you see the temporalis. The temporalis muscle. So the insertion of the temporalis muscle goes through through here, okay? Goes through there. It gets to the mandible. Okay, the zygomatic arch, right?
Yeah.
So it goes through there, inserts on the coronoid process. Now, you know that bone is tension adapted, right? So when we have a muscle attached to a bone, if it's attached with soft tissue sort of interdigitation in the bone, and it has little fibers called Sharpie's fibers that stick into the bone, and so the muscle, through its tendinous attachment through the periosteum, is attached to the bone. And we know that muscles can pull, right? And so when the muscle pulls, it can stretch the periosteum here. It can stretch the periosteum here. So it makes sense then, this is one of the places in the face where you can actually see that the muscle attachment shapes the shape of the bone. So if you have an overactive temporalis, sometimes people get a large coronoid process like this. And in fact, as Brian was saying, the coronoid process can get, it shouldn't, but it's pathology. But the coronoid process can get so big that someone can't open their mouth because the coronoid process stops their mouth from opening. And it's pathology. It's not the way it would normally happen. I mean, I got this old ancient mandible. All right, in the back row, ready?
Yeah.
All right. So that mandible is a mature mandible, but it doesn't have any teeth. We'll talk about that later. See how that doesn't have any teeth. So does a coronoid process, doesn't it? Verify that for me. Does that bone have a coronoid process? Okay, it has a coronoid process. That's because the function of the coronoid process is the attachment of the temporalis muscle. And that person still had a temporalis muscle. What do you think would happen if you had some disease of the temporalis muscle and you had no innervation? What would happen to the coronoid process? They would be bigger or smaller than average? Be smaller, exactly, because it's not getting that stimulation of the muscle contraction. Okay? So, you understand that now. That's good. I'm going to go down to another, this one's pretty easy to understand, so I'll take this one next, especially since the gentleman has the mandible in the back. So I'm going to leave 3, and I'm going to leave 4, and I'm going to go to 5. 5 we call the alveolar process, the alveolar process. The alveolar process, the function of the alveolar process is what?
Hold the teeth.
Hold the teeth, exactly. In your mandible back there doesn't have any teeth. Does it have an alveolar process? No, it's gone. It's just a corpus. So if you look at a mandible, here's another one that's sort of a dentulus. You don't have to throw it, you're right in front of me. Want to look at this one? Anybody back there? No?
I want to get
All right, so when we don't have teeth, we don't have an alveolus. So when you're making a denture, when you're making a removable denture like you'll make probably before you graduate, you're replacing no teeth, right? So denture doesn't replace teeth. Denture replaces no teeth. So you always want to tell your patients, they say, can I replace my teeth? You say, no, teeth are irreplaceable. We can replace no teeth with a denture. But we can't replace, that's not a replacement for teeth, all right? So dentures replace no teeth. And in fact, you should probably, they don't care, but you're also replacing, not only are you replacing the denture, but what else are you replacing? The alveolar process. And that's why dentures aren't just white pieces of teeth that are stuck in people's mouths. They have the pink part, right? The pink part is the alveolus. And back in the old days, before people had implants for their dentures and things, they would have to reline their dentures. They would get a denture, okay, and they would wear it for a couple of years, and then they'd come back in and they'd say, Doc, my denture doesn't fit. And the doctor would go in and they would add more pink acrylic. They wouldn't change the teeth, but they'd change the pink part. Why? Because the alveolus was resorbing. So the alveolus undergoes disuse atrophy, which means that there's no reason for it to be there anymore when you lose your teeth. So in a person that has no teeth has no alveolar bone, eventually. Now when you first take out the teeth, right, you're taking the teeth out of the alveolus. So when you first take teeth out, you do have the alveolus there, right? Because but it's got holes in it, right? It's got the holes where the roots of the teeth used to be. So somebody that comes in and has all their teeth out, they still have an alveolus at the beginning. You make them a denture, the pink part doesn't have to be that thick. But then as they get older, the alveolus resorbs and resorbs and resorbs until you get to somebody who's like probably 60 years old that's had no teeth since the time they were 20. All they have is a corpus. And that's a huge problem. Because if all you have is a corpus, then the top of the corpus in the edentulous mandible, the top of the corpus in the edentulous mandible, like right here, okay, right there, okay, and if you look at the back of the mandible, you've got these genial tubercles. So when you look at the mandible, all mandibles have genial tubercles, but you got to have a complete one to see them. Some of these that are cut in half aren't so good to see it, but in this, yeah, see, you can barely see this, but look at this line right there. What's that line? That's the mylohyoid line. Here, take this one and look at it. Okay. So you look at the mylohyoid line, and the mylohyoid line, here it is here, but this one still has some roots in it, you see, but the mylohyoid line is like right along there. What is the mylohyoid? What does the mylohyoid do? The mylohyoid is the floor of the mouth, right? That's where the muscles attach. That's where the muscles and the base of the tongue, in order for the tongue to stick out, right, you've got to contract the mylohyoid to make the floor of the mouth firm, and then you can stick your tongue out, right? So what happens, do you think, with a denture now that's sitting on the mylohyoid? It's a problem, right? Because the denture's plastic and the person's trying to eat and they're moving the mylohyoid. So basically, eventually what happens is the denture's sitting on a flat surface. It doesn't have any grip, all right? And that's why people use polygrip, right? So they try to stick it to the gums. And now what do we do? What's the solution?
You know, that
Yeah,
is what,
implant.
that
Implant.
was good.
Was that the question?
Yeah, how does an implant
An implant to work,
avoid disuse?
well, because the implant itself functions like the root of a tooth, right? The implant functions like the root of a tooth. So if you put an implant in, it prevents the disuse atrophy. So if you put an implant in, when you, like you take out the teeth and you put an implant in right away, usually people don't lose all their teeth at once. What's the last tooth to be lost in the mouth usually?
Maxillary canine.
K9.
Mandibular canine. But you were close, it was a canine. Mandibular canine's lost last, and then what else is then? Lower anteriors. A lot of times people have no upper teeth, they only have 6 lower anteriors, lower canines. So if you only had 2 teeth left, you can have a partial denture, right? But those last 2 teeth, if you took out the canines, you could put implants in there. When you put implants in there, then they can run a bar across it, and they snap the denture on that bar. And it replaces, the implant replaces the root of the tooth. And then the crown replaces the part that you see. So it's a 2-part thing, yes.
My question is, you remove, what is inducing osteoblastic action?
Osteoclastic or osteoblastic?
Osteoblastic, so that you don't lose bone.
Oh, the fact that when an implant is there, well, we talked about this the very first day. Okay, so who remembers, how does the implant become attached to the bone?
Osseointegration.
Osseointegration, which is caused by cutting and filling cones.
Right,
So the cutting and filling cones go around the implant like this. And so you say, why does that bone not resorb all the way down to the implant? Is that your question?
Because you remove the PDO, so you've removed that trauma. now.
Yeah, but you remove the PDL, but what you still have is micro stimulation through the implant and the forces on the implant. And that is enough to keep the bone, you know, have some structure. If this was a huge problem, in fact, the very, very first experiments that were done in space had a lot to do with bone density, because people weren't sure what would happen to the human body when you were in space for a long time, because you wouldn't have that stimulation, and you need like it's called micro strain. You need a little bit of strain on the bone, a little bit of micro strain on the bone to maintain its position. And the implant turns out to provide enough micro strain to preserve the alveolus.
So it's not perfectly osseointegrated, there's.
Yes, it's enough so that you keep it. It doesn't move. It's only, once it's osseointegrated, it doesn't matter if the whole thing is osseointegrated or just half of it, doesn't matter. You still preserve the bone. You still have the micro strain. You need some micro strain, whatever we want to call it. People wouldn't call it trauma. Trauma probably implies like some pathology, but micro strain, and then that preserves the alveolus. Okay, but so remember that when you're making, yes, you have a question.
Yeah, so even on these like mandibles that are edentulous, there's still like a, on the cross section, still like almost like a line between where it's like kind of really spongy and really dense.
Yeah, some of those might not be totally resorbed all the way, but they're
so
close.
That is kind of alveolar process. Where it's
Whatever's left is the remnant of the alveolar process.
Okay.
Exactly right. Exactly right. So whatever is left, whatever little bit of bone is here, whatever little bit is there, depending upon how long the person hasn't had teeth. And also, if you have a denture, this is a good question. This would be a good exam question. Okay, if a patient, I'm not going to use it, it's too common. If you get it, then it'll be good, right? So if a patient of yours had all their teeth extracted, would the alveolar bone dissolve faster if you made them a denture, or would it dissolve faster if you just left it with nothing? They could just gum their food.
It'd be faster with the denture, because now you're not getting any stimulation.
It was faster with the denture because of the pressure. Yeah, that's what I think. I don't know. Nobody's ever done the experiment. I guess we could try some people in the class and make half the teeth or something, make them half the denture. But because of pressure, what happens to bone under pressure? it resorbs, right? Bone under pressure, now teeth need microstrain, bone needs microstrain, but the microstrain has to be delivered as a tension. It can't be delivered as pressure. So when we talk about microstrain, and we're talking about that, the microstrain occurs on the titanium implant. It's not like microstrain on the bone. It's microstrain here that's transmitted to the bone. So just so you understand the difference between that. So it's not pressure, because under pressure, bone resorbs. Under tension, bone forms. It's not quite that simple, but that's a good starting point. Yes?
When we talk about implants, so if you have a patient that they're going to have a tooth extracted and they already know they want to get an implant, is it better to do that immediately, like place the implant, rather than waiting and letting the bone start to resorb?
It's a great question. It's a great question. And the answer to the question isn't as simple because, you know, clinical care is never quite as simple as basic biology. But if it's a single-rooted tooth, then yes, you want to replace the implant right away. Because most implants are like a single-rooted tooth, okay? But if it's got 3 roots, the problem is, where do you put, the implant has 1 root. All implants, you know, even if it's replacing an upper molar, like the implant still only has 1 effective quote-unquote root.
So
Right.
then would you have to?
So what most people will do now is rather than just let it resorb on its own, they'll take the tooth out and then they'll pack it with bone, you know, fragments to preserve the ridge height, let that integrate, and then drill into the center. But that's a great question. You're thinking exactly the way modern dentists need to think, is like, okay, what's the underlying biology behind what I'm doing in my office? And then this is why I'm doing this versus that. Because you gotta be able to explain that to the patients. You gotta be able to tell them why you're doing something. You know, you just can't say because Dr. Hans said so. I was the first year dental student. Because I won't be there, okay? So you gotta know yourself why you're doing that. That's a great question as far as why, yes.
Which one resolves faster
With the denture, I think, nobody's ever done the experiment, and only because when you have the denture, right, you're constantly putting pressure on the alveolus, but it's not the kind of pressure that stimulates bone growth, like microstrain, it's pressure that resorbs bone. So having a denture probably makes you lose your alveolar bone faster.
Isn't there pressure on the long bones when you walk around?
Is there pressure on the long bones when they walk around? What happens on the long, that's a great question, right? It's a great question that we know the answer to if we think about the physiology of the long bone. What's on the end of the long bones? Cartilage. So what transmits then, what's resisting the pressure? The cartilage, okay? And the cartilage then is the shock absorber that allows the pressure that's on the bone to get to the microstrain level, okay? Because you're right, what happens when you lose your cartilage? What disease do we call that? Everybody gets it when they go. Arthritis, right? Arthritis is degeneration of, and then what happens? Well, then it hurts when you move your joints, right? Because you don't have that adequate support. So those are all great questions that help amplify sort of what I'm talking about here. So the alveolus, its primary function is to support the teeth. And we'll talk more about alveolar growth and more about tooth movement. That's another lecture. But the alveolus is important there. So now we've left with 2 places, 3 and 4. And 4, people call the corpus. And the porpoise of the corpus, okay? So the purpose of the corpus. Okay? The corpus, what does corpus mean? Body, exactly. It's like corpse. What's a corpse? A dead body, right? But a corpus just means body. Okay? So the corpus is the body, and the corpus provides essentially the same function as Meckel's cartilage, right? It connects the right and the left halves of the temporomandibular joint. It allows the mandible to function, right? And so it forms the attachment point for all the muscles that aren't the temporalis, right? So the temporalis attaches here. At the angle of the mandible, right here, 2 really important muscles. One,
The masseter?
masseter, and what's the one on the inside called? Internal pterygoid. Internal pterygoid. The pterygomasseteric sling. So remember, pterygomasseteric. So the pterygoid, okay, it's not the external pterygoid, it's the internal pterygoid. Pterygomasseteric sling is the one that goes around the bottom of the corpus of the mandible. The pterygomasseteric sling, since it's called the pterygomasseteric sling, the masseter is obvious, right? So then you know it has to be one of the pterygoid muscles. Okay, one of the pterygoid muscles. So now you have to memorize the fact that it's the internal pterygoid. There's no way to figure it out.
Now, is
Would that be
It's on the
medial or
inside, yes?
lateral?
What?
Would that be medial or lateral? 'Cause
It's medial, the medial pterygoid.
Yeah.
Internal pterygoid is the medial pterygoid.
Okay.
Yes,
Thanks.
and the lateral pterygoid is the external pterygoid, so they call it that. But where's the lateral pterygoid? Where is it? Because the lateral pterygoid actually has an insertion. Where's the lateral pterygoid insert?
on the right?
Top there? In like
In
this?
the pterygoid fossa, on the anterior border of the condyle, right? That's where the pterygoid inserts. So where's its origin? The pterygoid plates. So it goes from the pterygoid plates to the condyle. And so if you imagine now, what's the purpose? What movement does the lateral pterygoid give you with your mandible? If it attaches to the condyle and the other attachments at the pterygoid plates, when it contracts, what does it do? It moves you forward. Yeah, forward, and it has to be different, right? So the lateral pterygoid is here, okay? So it's a little bit medial, right? It's a little bit medial, right? So it can give you a little bit of a side shift is what you're talking about there, right? Because there it is right there, and there's the condylar fossa. Condylar fossa is right here, and there's it. So it does have a medial, it can pull this way, right? The lateral pterygoid. But generally, if they both contract, the mandible comes forward. And if you track one, you can get a little bit of what they call side shift. Yeah, obviously you got your articulators out, so you're talking about side shift, right? So side shift is caused by that, right? Because the lateral pterygoid, I got this upside down. All right, you figured that one out. But I mean, the condylar heads are here, the pterygoid's there, so it can cause a little bit of side shift. But side shift is actually caused by the fact that the condyle doesn't fit perfectly in the fossa. I could show you side shift in your elbow too. That's just the flexibility in the joint. You know what I mean? So there's side shift, there's that sort of thing. All joints have some laxity, and side shift is just a way of measuring the amount of lateral laxity in the temporary of the joint.
So were you suggesting earlier that infants don't have pterygoids?
No, infants that have pterygoids, it's probably the only thing that really is developed, because all I have to do is bring their mandible forward and bring it back.
So the pterygoids move side to side?
This is what I was trying to say. The pterygoids are. This is how they are. Right? The pterygoid goes from the condylar head to here, but in the infant, it's almost straight.
Okay, so it's not that they are developed; it's a different angle.
It's a different angle. And as you get older, you get this, right? So, but what I'm trying to say is that the pterygoid muscles, the mandible can't be compressed really, right? So if a pterygoid muscle contracts, if they both contract together, the mandible's going to come forward. So when you do this, you're doing bilateral contraction of your pterygoids. Okay? Yeah. So that's bilateral contraction. If you do one, then you got more contraction on this side, right? And you do the other one, you got more contraction on this side. So you can make it shift to the side with the pterygoids like that. We always get into so many interesting topics. Okay, those are not in the learning objectives. That's extra stuff you just learn for no reason. So the corpus of the body is there for the pterygomasseteric sling, for the muscles. It's there for the genial tubercles and the mylohyoid line and all of the things that need to, like all the muscles that need bilateral function. So the corpus, without the corpus, we'd have a huge problem. All right. Corpus is really important. It is the strut. Okay, it is the strut, but it's by and large a sort of inert. You know, it's there. It has the muscles attached to it, but it's not a huge area of growth. Well, one of the reasons it's not a huge area for growth. Okay.
But isn't that what gets larger over the?
Yeah, and it doesn't exactly. So that's exactly right. Why? It can't grow into the muscles. Why can't the mandible grow down into that pterygomasseteric sling? No, it can't, right? It's not going to grow there. That's not where you're going to see new bone, because you've got the pterygomasseteric sling there. All right, so when you see new bone formation, it's not gonna be on the bottom here, there's hardly any new bone on the bottom. All the bone is formed on the top.
So it's not
And in the back.
down and out, it's up and out?
It's like this, down and forward, but all the change is in the part of part of this bone that we haven't mentioned yet, what we call the ascending ramus. The ascending ramus, its primary function, the primary function of the ascending ramus is growth. I wish I had better chart.
That's 3.
All right, growth. What's the primary function of the ramus? What is it? Growth. Growth. And it's growth horizontally, and it's growth vertically, and so it is responsible when we get displacement of the mandible downward and forward. The primary area of deposition of new bone, the primary area of deposition of new bone is in the ramus. The primary difference. So where is the free surface? Because we know that deposition can only happen on free surfaces, right? So some stuff we can figure out just by understanding anatomy. Where's the free surface on this ramus? Is it in the front? No, we've got stuff here.
Well,
It's in the back. It's not in the front. Now, interestingly,
well, until the wisdom teeth show up.
interestingly, I drew this as 2 dimensions, right? Interestingly, I drew this as 2 dimensions. Remember, we know the mandible is growing downward and forward. They're actually, this anterior border, if I looked at the condyle now, and you look at the coronoid process, and you look at the alveolar process, you'll see that the alveolar process is actually, this is a totally wrong scale. All right, is the alveolar process of all of these mandibles that are going around. The alveolar process, who's got a mandible that's a whole mandible? A whole one, you know, it won't be obvious. It might be, but you gotta know what you're looking for. All right, you can't, you know, you could hold it like this and it wouldn't be wrong. But if you look directly down and on the alveolus is lingual to the ramus. The alveolus is lingual to the ramus. The alveolus is growing lingual to the ramus. Okay? Where do the third molars grow? In the alveolus. Okay? Lingual to the ramus.
So they don't get in the way.
So they never get in the way, but why do dentists think? Why do dentists think that third molars are growing in the ramus? Because I could tell you if you asked.
Because it looks that way on an x-ray.
There you go. It's $1 million extra. Because we look at everything like this, right?
Right.
We look at everything as a 2-dimensional representation of a 3-dimensional structure until about 10 years ago, when dentists finally started looking at cone beam CTs, actually any kind of CT. You know, medicine had spiral CTs for a long time. They were used to the 3-dimensional stuff, but dentistry was not. Almost all of our x-rays showed we're 2-dimensional, and they superimposed the ascending ramus here on the alveolus, which gave people the false idea that the third molars were growing in the ramus. And for that reason, people would say, oh, your third molars will never have any room because they're growing in the ramus. But they're not. Third molars develop lingual to the ramus. Lingual to the ramus. So what's happening with this ramus? What's happening with that ramus right there in terms of growth and development? And this is, the mandible is being displaced downward and forward. Interestingly, the posterior border of the ramus is largely depository. It's largely depository. So the posterior border of the ramus is one of the major areas of deposition of new bone in the mandible. The posterior border of the ramus. Okay? Because the coronoid process limits the oral cavity. The oral cavity sort of ends here, right? So for a tooth to get into the oral cavity in the mandible, we need resorption of bone on the anterior part of the ramus. That's how we lengthen the alveolus. The alveolus, like when you looked at those second graders, right? You had the second grader, and I told you about doing the maxilla. Are you going to do more of them? Are you going to do it again or not?
Next year.
It's too late? Okay. So next year, if you remember, find out that you'll find the same darn thing is true in the mandible. At a 7 or 8 year old, you won't have room for the 12-year molar. Your finger and that kid is going to be right there. And you're going to be able to palpate the anterior border of the coronoid process, the anterior border of the ramus. Not the coronoid process up here, it'll be the anterior border of the ramus. You're right here. So somehow, miraculously, through growth and development, most, if not all, of your 6th graders that you saw had 12-year molars in the lower and 12-year molars in the upper. How did it happen?
Is that under the direction of stem cells or the brain?
No, it's not. Stem cells are long gone by this time. This is the reaction of surface phenomena. The surface phenomenon we call remodeling, which is a combination of deposition and resorption. So in the ramus, the anterior border is undergoing resorption. And the posterior border is undergoing deposition. I'm going to get rid of the condyle here just because it's harder to draw. So we get progressively the ramus is moving posteriorly and superiorly. And although you'd think that the condylar cartilage would be really, really important for the vertical growth, it turns out if you cut the condylar cartilage off, or if you break your condyle or something like that, hardly affects it at all. So the fact that the condylar cartilage is there and is capable of forming bone is not critical to growth. Now, in a normal individual, yes, there is vertical growth of the condyle, and so it helps, right? But it's not necessary. If the condyle wasn't there, the mandible would still grow vertically. How would it grow vertically? Remodeling. So in the absence of endochondral bone formation, you would get remodeling of bone, you'd get bone deposition. So what's happening here, in order to get room for the next molar tooth, you need to resorb the anterior border of the ramus and deposit bone on the posterior border of the ramus. And remember that as you're resorbing the bone on the anterior part of the ramus, you're getting more room in the mouth for teeth, right? Does that make sense? So, if you ask yourself, why is there not room in we're almost done. We had a couple of digressions. Why in the 16-year-old is there not enough room for the third molar? Still growing. And in particular, what's still happening? Resorption where? On the anterior border of the ramus and deposition on the posterior border. And the tooth is growing lingual, and actually we have a special name for the back of the alveolus. For the back of the alveolus. In the maxilla, remember we had a special name for the back of the maxilla. What did we call it? The tuberosity. Exactly. So if there is a God, then there would be a mandibular tuberosity. Right? Because he wouldn't just make a maxillary tuberosity, or she. All right? She wouldn't just make a maxillary tuberosity, she'd make one on the mandible too. And in fact, the mandible has a mandibular tuberosity. But the weird thing is if I'm looking at the most common x-ray that we use in dentistry is like a panoramic radiograph, right? A panoramic radiograph, if I'm looking at the mandible, right? If I'm looking at the mandible versus the maxilla, there's a maxillary molar, the panoramic radiograph shows me the posterior border of the maxillary tuberosity. So the radiograph shows you the posterior border of the maxillary tuberosity, the one that collapses everything together. But the mandibular tuberosity is lingual to the ascending ramus and cannot really be seen on the standard bite wing or periapical or any x-ray that's a plain or two-dimensional x-ray. And that causes lots of problems. Because people would say, oh, I'm looking at that, yeah, there's room on for the third molars on the top, but at the bottom, they're in the ramus. Let's take all four of them out. Yeah.
No, but in utero, as it's going, bud cap bell, you've got those bells that are there already. They are there. The teeth.
Yes,
the tooth
but
doesn't
but
grow.
when does the bone respond to that as the tooth develops? As the tooth develops, bud, cap, bell, you start with the buds, and then you get the cap, and then you get the bell, but at the same time that that's happening, you need to get bone for that tooth to move into. So in other words, if you're looking at the maxillary tuberosity, okay? The maxillary tuberosity here, say this is your first molar, well, the second molar might be in the bell stage, and then maybe over here, all you do is just have a little bit of a shadow that's the third molar, that might be even in the bud stage. Okay, so what's happening is, as you're getting new bone, and it's easier to understand in the maxilla because it's simpler, this tooth is doing this, and then eventually this tooth is doing that,
Okay.
as they're developing, yes.
Will that resorption and the position going on in the borders of the ramus would be affected with the forces of mastication, or it has nothing to do with it?
It's really interesting. There are people that think that just the forces of mastication, especially the how hard your food is, can make your bones grow more, okay? But it's not clear, it's really true. I mean, there was a guy here that had a bunch of green monkeys, and he kept them over in medical school, and he fed half of them mush and the other half hard pellets, and he tried to see whether or not their bones grew differently. And they did. But people thought that. I mean, that was what people would think, that stimulation, the muscular stimulation. And so people are still sort of working it out, what exactly is driving the force, the face, other than the cranial base, which we know is synchondrosis, the brain, which we know, the neurocranium, the flat bones of the skull, which we know is brain. As we move further away, it gets more and more cloudy as far as really what's happening.
So, going back to the alveolar process.
Yes.
So, when we extract it, the bone is going to resolve.
Yes, it does.
So why don't we, with every extraction, why don't we just fill it with bone graft? At least it's going to slow down how it.
Yes, that's true, and I think that every extraction with which you want to restore with a tooth, people now put a bone graft in. But like a third molar, it's the end of the arch, you're probably not gonna put a tooth back there, so a lot of times they don't bother there. But any other tooth, when they extract it, like a single rooted tooth, instead of putting the bone in first, they'll probably put an implant in, because it saves one step. Okay, one surgery.
Just made the hole.
Because as long as the hole's in about the right spot, as long as the hole for the root is about where you want to put the implant. Now, those are good questions, really good questions.
So it's only with the three-rooted,
Or two roots too, you have this, and two or three, anything where it's not a single root, I think that'd be a good question for Fadi.
what if like the root just happens to be like really long, even if it's a single root?
It doesn't matter, you wouldn't make the implant that long, you'd still only make, because remember the implants, we're only interested in having, you don't need it to be that thick.
Yeah.
So the implant doesn't go all the way down to the tip of the root.
So would you put bone graft underneath it?
No, you just let blood come in and it just,
Oh, really?
yeah,
Okay.
you don't, you just screw it in and then you just get, yeah, you just get the bone healing basically. All right, any other questions? All right, well, I'm glad you came. I'm glad I was here. All right, next week, remember that we're going to meet, I think, earlier on Wednesday. So it's in your schedule. If you look at Canvas, instead of Dr. Weinberg, I think I talked to you on Wednesday. And then he comes on Thursday. Okay? Thank you again.